be talking about anorexia nervosa. So, the symptoms of anorexia nervosa include an intense fear of gaining weight, severe calorie restriction, and significant weight loss. Individuals with this condition might drastically restrict their food intake or even engage in excessive exercise to prevent themselves from gaining weight. The prevalence of anorexia nervosa, over 90% of AN cases, I'm going to say AN throughout this presentation to indicate that I'm talking about anorexia nervosa, but over 90% of AN diagnoses are in female identifying individuals, and it primarily affects adolescents and young adults ages 10 to 25 years, and that's over a wide range of socioeconomic backgrounds. Individuals who identify as LGBTQ+ are 3 times more likely to develop an eating disorder like AN. Black, Indigenous, and people of color experience AN at similar rates to white individuals, although fewer than half receive a diagnosis essential for treatment. And then individuals with disabilities are at higher risk of developing AN as well as transgender individuals. Why is this a problem? AN can lead to serious health complications, including heart disease, bone deterioration, organ failure, and even death. AN is the 3rd most chronic psychiatric disorder among girls and women and holds the highest mortality rate of all psychiatric disorders. AN can have profound effects on individuals, families, and communities. Those affected often experience anxiety and depression alongside serious physical health complications. AN can result in a loss of income, financial strain on families, and diminished quality of life for individuals suffering from it. Okay, and then I'm going to go into the interventions that I highlighted in my paper. So the ones that I found that were level A include family-based treatment. It's widely used and effective intervention for the treatment of AN among adolescents. The next level A is enhanced cognitive behavioral therapy, addresses maladaptive thoughts and beliefs related to food and body image. And then level B interventions would be the Maudsley anorexia nervosa treatment for adults, also called MANTRA. It's a type of family-based treatment, and it targets cognitive and emotional factors that contribute to the persistence of anorexia nervosa. We'll get into that later. Another level B would be specialist supportive clinical management, which combines clinical intervention techniques with supportive psychotherapy education. And then the next level B would be psychotherapy, specifically targeting identity in therapy with individuals with AN. Many individuals with AN closely link their sense of identity to the disorder, which can create challenges in their treatment. And then the next level B is cognitive remediation therapy, or CRT. So it's defined as an approach to help modify maladaptive behaviors, targeting and challenging the underlying cognitive processes that contribute to AN. The next level B is exposure therapy, a treatment approach proven effective for individuals with obsessive compulsive disorder and post-traumatic stress disorder. It works by addressing challenging cognitive distortions related to anxiety. And then the next level B would be neuromodulation that is non-invasive, such as repetitive transcranial magnetic stimulation, transcranial direct current stimulation, transcranial direct current stimulation, and vagus nerve stimulation. And then going into the more ineffective interventions, level C would be pharmacology, antidepressants such as SSRIs that include fluoxetine, Paxil, Zoloft. They're widely used to treat comorbid conditions such as anxiety and depression, but there's no direct link to their effectiveness in treating AN. So that's level C. And then the next level C is olanzapine, which is a mood stabilizer. It might have some effectiveness in increasing weight gain and reducing symptoms of anxiety, but there isn't a lot of strong evidence for that. So that's level C. Individual therapy has shown decreased effectiveness when compared to family-based therapy, so it's really important to involve the whole therapy. So that's also level C. And then self-help interventions, which has some success with participants, but only one study so far has been conducted to prove its efficacy. So that's also level C. Okay, the interventions that I'm going to focus on include the Maudsley anorexia nervosa treatment for adults, also called MANTRA. It was developed in London. It's based on cognitive interpersonal maintenance model of anorexia nervosa. It focuses on factors like emotional avoidance, rigid thinking styles, and poor social functioning. The evidence supporting MANTRA, early studies showed promising results in terms of feasibility, acceptability, and symptom improvement. And then also patients generally reported higher treatment satisfaction compared to other models. The strongest evidence comes from the ANDA trial, which was published in 2015. It compared MANTRA to specialized supportive clinical management, SSCM, which is another one that we'll be talking about today. Both treatments were similarly effective in terms of BMI and symptom improvement. It showed that MANTRA was a better patient-rated acceptability and treatment alliance. And then there was a slight edge in reducing eating disorder psychopathology at 12 months follow-up. So a 2020 review concluded that MANTRA is a viable and acceptable treatment option for adults with comparable outcomes to other therapies like CBTE and SSCM. And the dropout rate is lower in MANTRA compared to other treatments. There's still relatively few large-scale RCTs, and then long-term recovery outcomes beyond 12 to 18 months are not well studied. And there's no consistent evidence that MANTRA outperforms other treatments in all clinical domains. But it's considered a well-supported treatment, so that's why this one is rated a B. The next one I'm going to focus on is SSCM, which is the Specialist Supportive Clinical Management. It's developed as a control condition for anorexia AM trials, but over time it's gained recognition as a credible standalone treatment, especially for adults. And it combines clinical management of malnutrition and non-directive supportive psychotherapy. Focuses on weight restoration, physical health, and providing emotional support. Therapists follow the patient's lead and avoid highly structured interventions. It really emphasizes rapport building and helping patients explore their own motivation for change. So there was a study that was published in 2005 that compared SSCM with CBT and interpersonal therapy, and it had outcomes equal to or better than CBT and IPT at 12 months for weight gain and symptom improvement. And then the other big trial that was published was the ANDA trial, which I talked about, that compared SSCM to the MANTRA. And it showed slight advantages in patient-rated alliance and satisfaction, but SSCM really performed very well. In multiple reviews, it's been a treatment as usual comparator, but shows clinically meaningful improvements in weight restoration, symptom reduction, and patient retention. It's not designed to address core psychological maintaining factors, however, like perfectionism and cognitive rigidity. So it may not be sufficient for severe, chronic, or treatment-resistant cases of AN. So that's that. And so talking about the gaps in the research, so understanding the neurobiological mechanisms related to AM is something that needs to be further studied, because the more that we know about what's going on in the brain, the more that we can focus on figuring out treatment modalities that will be helpful for that. There's limited effective treatments for adults. A lot of the studies really focus on adolescents, and there's poor representation in research. Most of the clinical trials focus on cisgender adolescents who are female, and there's limited data on males, transgender individuals, and people of color. Okay, thank you so much.